We continue our discussion on stroke. Now, let's see how to investigate a case of stroke. Well, when the patient comes in the emergency room with some clinical history and finding suggestive of stroke, the first investigation is always CT scan. It is without contrast. Okay, why is it so? Remember, wherever the blood is there, we don't need a contrast because that will hamper the evaluation. So now, one more thing, 80% of the strokes are due to ischemia and 20% stroke are due to bleed or so-called hemorrhage. And one more thing, CT scan, plain CT scan, if done within first 12 to 24 hours, it is normal. Then the question is why we want to do plain CT when we know that 80% are ischemic stroke and is going to be normal. The reason being, CT scan is a much better modality to differentiate hemorrhage as compared to MRI. So MRI cannot pick up early hemorrhage. So that's why we go for plain CT scan. If CT scan is normal, that rule out hemorrhage is there. So what I mean to say, we do early plain CT scan not to look for ischemia, but to rule out hemorrhage, because treatment differ in both the modalities. So that's why. So let's presume that we have done plain CT scan is normal. So it is understood that patient has ischemic stroke. So what to do? Well, once we have proven it, other blood tests will be doing anything which predisposed to increased thrombus formation or embolic. So we like to do ESR, we like to do VDRL, ANA, protein C, protein S deficiency, anti-phospholipid antibodies, factor V latent mutation, all these which lead to predisposition to increased clot formation. We like to do ECG and Holter study to rule out any ischemia or any arrhythmias. Echo to look for any clot, and carotid Doppler study to rule out any internal carotid artery stenosis, any stenosis in the internal carotid artery. So they are the basic investigation. But remember, ultimately to confirm ischemia or anything which is any stroke, in fact, most accurate is MRI. Why? Remember, CT scan cannot pick up posterior fossa clots or posterior fossa ischemia, to be more precise, it cannot pick up. But MRI is much better modality, but little more effective after 24 hours, not within first 24 hours. Well, we also do carotid angiography. To what for? To identify, quantify atherosclerotic stenosis, aneurysm, spasm, interluminal thrombi, fibromuscular dysplasia, AV fistula, vasculitis, collateral, and of course to look for any bleeder, any bleeding site also. Okay, and ultimately bleeding site has to be taken care by maybe suppose patient has rupture of Berry aneurysm, then neurosurgeon has to clip this bleeder. Now ultrasound technique is nothing but Doppler study, mainly to look for the carotid artery stenosis, about which I discussed. Now there are few investigations which are routinely not done, but if you have to demarcate the cerebral perfusion area, then PET scan and SPECT are done, but remember they are not done in a routine patient. Now how to manage this case? Well, our ultimate aim is to prevent or reverse the brain injury. So we do management in different aspects. First is medical support. In fact, this is one of the best early thing that we have to do. What we do, first of all, in any case of stroke, BP has to be controlled. This is one of the most important thing, because that's the one which is going to increase the stroke and cause more and more damage to stroke also. So if BP is more than 185 by 110 is too dangerous, then we have to use some anti-hypertensive drug. Maybe we can even use injection esmolol. It's a very short acting drug, but it reduces the BP very fast. In the meantime, we give other anti-hypertensive drug to reduce the BP. Cerebral edema is another problem. Then we have to give mannitol. Then we have to give deep vein thrombus prophylaxis. That is by early physiotherapy of the leg. Maybe we give pneumatic compressors, or even we can start low molecular weight heparin. But point to be noted, low molecular weight heparin is only for deep vein thrombosis. It has got not much role in clot in the brain. And of course, in addition to that, when we talk about medical management, we also like to control blood sugar. We like to give statin. In fact, all patients of CVA should be given statin if they have a high lipids there. And other supportive management, bed care, care of the bladder, etc. has to be done. What we do is in a routine ICU setup, and I don't need to monitor that. We have to look for the oxygen saturation, and of course cardiac monitoring has to be done. All our so-called medical support that is done in a routine ICU. Now, as far as our main particular management in relation to CVA concern, aspirin is the best antiplatelet drug. Well, we can give dipyridamole or clopidogrel if patient is already taking aspirin, then we can even switch over to this. But most of the now recent updates, they say aspirin is the best antiplatelet drug. Low dose we give. Now, third entity is to look for to take care of the thrombus. So we go for thrombolysis, and we use recombinant tissue plasminogen activator, RTPA we use. It's the only one which has been approved for this thing. And when we use, first of all, we are sure that our clinical diagnosis of ischemia is there. Remember that we presume that that CT scan is normal, and CT scan shows no hemorrhage, and there is no cerebral edema, then and symptom duration is less than 4.5 hours. This is the recent update. Previously it was 3 hours, now it is 6, the 4.5 hours is the time that we can go for thrombolysis. And age should be below, it should be more than 18 years. Okay. Now, what are the contraindication where we do not do? The contraindication is of thrombolysis if BP is more than 185 by 110. Despite treatment, the patient still has very high BP, then thrombolysis should not be done. Number 2, patient has bleeding diathesis. Patient has recent head injury or recent CVA, because a recent bleed in the brain should not be done. Then major surgery within last 14 days. Massive GI bleed last 21 days and recent MI. They are some of the important, and of course age below 18 years that we discuss. So there are a few contraindication of not where we will not like to go for thrombolysis. Now this is a new thing has come up. Mechanical thrombectomy, what we call as, also known as endovascular mechanical thrombectomy, especially done where the artery blockage is a major artery in the brain, then they put a catheter and they try to remove the clot. This is the recent thing has come up. And as I told you, statin should be given in all ischemic stroke because to look for the lipid. Well, now what about cerebral hemorrhage? Whenever cerebral hemorrhage occurs, a neurosurgeon should always be consulted, especially if bleed occurs in the posterior fossa. I have said especially for posterior fossa. Do you have idea why I am saying? You can stop the video for a minute, write down the answer. The question is, why in posterior fossa in particular? Of course, for any cerebral bleed, neurosurgeon should be consulted. But my question is, especially for posterior fossa, neurosurgeon should always be consulted. Write down the answer. I hope by now you have written the answer. The answer is, in the posterior fossa bleed, especially so-called cerebellar bleed, we do CT and we are getting bleed in the cerebral, posterior fossa, cerebellar bleed is there. Remember, it's the only place where surgeon can operate and can remove the blood. Now, a word about cerebral bleed. In the entire bleed, wherever, maybe anterior part of brain or maybe frontal temporal or even parietal lobe, most of the time they are non-operable. We have to manage medically. Of course, in the medical management I'll discuss shortly. But in posterior fossa, in cerebellar bleed in particular, it's the only place where we can operate when we can remove the blood. That's why if done early, you get the best prognosis. But at the same time, cerebellar bleed is there and you do not operate, that will lead to coning of cerebral tonsil. This is cerebral tonsil. This spinal cord, and this is the cerebellum. And bleed is there, intracranial, and bleed will lead to posterior fossa is a very close chamber, and bleed will lead to immediately increase intracranial pressure, and due to this pressure, this cerebellar tonsil will cone down. This is the foramen magnum, and this is the spinal cord, vertebral canal. The cerebral tonsil will cone down and patient will die immediately. So in nutshell, cerebral bleed has the best prognosis if treated early because we can operate, and if not, first person to die is again cerebral bleed because after all the hemorrhage at every place, the first to die is cerebral because of coning of cerebellum tonsil. Well, in a case of routine case of hemorrhage, we have to look for the intracranial pressure should be controlled. Mannitol is given. Airway has to be protected because they go into coma very fast because of raised ICP, and there should be all other supportive treatments should be done. Of course, we do not give no antiplatelet, no thrombolysis. We have to go for deep vein. We have to take care of the deep vein thrombus by physiotherapy and pneumatic compression. You avoid low molecular weight heparin here also because it can add to the problem. And statin, if lipid is high, give statin, sugar should be controlled, and all other medical management should be done. Now, neuroprotective, this is the concept. This is to reduce ischemic injury to brain. In other way, where we give, especially we use hypothermia. Hypothermia. By hypothermia, it reduces the ischemic injury to the brain, but it is very effective in cardiac arrest. But it is not a routine treatment in a case of ischemia due to CVA. Now, carotid artery stenosis. We can hear a brew over the carotid artery. That is a very sure, but a sign that some ischemia is there. Then what we use colored Doppler ultrasound. So it is a cause of emboli to the brain. And if a patient has symptomatic CVA, then endarterectomy can be done or carotid artery angioplasty is done. But endarterectomy is better than carotid angioplasty. And one more thing, if lesion is below 50% blockage is there, no role. In 50 to 70%, role is doubtful. So it is best for above 70 years, 70% blockage is there. But if artery is 100% blocked, then again there is no role because by the time 100% blockage has already occurred, body has already made this thing, collaterals have been made, so, and now it cannot be a source of embolus, so there is no role of doing any treatment when 100% artery is blocked. So you can say in nutshell, which artery, carotid artery should be taken care, more than 70% blockage and less than 100%. So quick recap of what we learned in this particular lecture. So best initial test is plain CT scan, but MRI is the most accurate test, but for the first 24 hours CT scan is the best. Cerebral angiography is the gold standard test, and Doppler study is for internal carotid artery stenosis, and to quantify cerebral blood flow we use PET scan and SPECT scan. Remember, PET and SPECT normally are not a routine investigation. In the management, medical support is very essential to control BP, sugar, airway. Antiplatelet drug aspirin is given. The only thrombolytic is RTP8, can be done up to within first 4.5 hours. Mechanical endarterectomy can be done up to 12 hours. Cerebral hemorrhage to control BP, sugar, raise ICP, take care of the deep vein thrombus. Carotid artery stenosis, more than 70% stenosis, we can go for endarterectomy or carotid angioplasty, but this is better than angioplasty. Thank you very much for watching this video.